Welcome back to Endo in a Bite. Today's bonus episode distills the last 4 sessions into board-focused pearls, framed as high-yield clinical objectives for both everyday practice and the upcoming ABIM endocrinology exam. Let's go step by step. We now recommend broad screening. In fact, the suggestion is to screen all hypertensive patients for primary aldosteronism, regardless of potassium status. The diagnostic evaluation rests on measuring both plasma aldosterone and renin as the aldosterone to renin ratio. Importantly, if a patient screens positive but further testing isn't feasible, it is reasonable to consider empiric initiation of a mineralocorticoid receptor antagonist. Suppression testing is no longer a blanket requirement. It is now suggested only when the probability is intermediate and the patient is a surgical candidate. We call this aldosterone suppression testing, not confirmatory testing anymore because its purpose is probabilistic, not absolute. Options include oral sodium suppression, the captopril challenge, or fludrocortisone suppression. And equally important, we do not use suppression testing in overt PA in patients not eligible for surgery or in those with very mild disease. When it comes to localization, CT alone is not sufficient. The guideline emphasizes that adrenal vein sampling is required to establish laterality before surgery. So AVS is the gold standard and treatment decisions hinge on laterality. Unilateral disease is treated surgically, while bilateral disease or non-surgical candidates are managed medically. For patients managed medically, mineralocorticoid receptor antagonists remain the foundation of therapy. Spironolactone is preferred over other MRAs due to its low cost and wide availability. If blood pressure remains uncontrolled and renin is suppressed, the dose of the MRA should be titrated upward. The principle is to ensure the dose is high enough to lift renin out of suppression. And as always, we monitor for side effects. And consider eplerenone in patients concerned about antiandrogenic effects. Adrenalectomy is offered only when unilateral disease has been proven by AVS. Another important update is the emphasis on testing for cortisol cosecretion in patients with an adrenal adenoma. A dexamethasone suppression test is recommended to rule out mild autonomous cortisol secretion. This is not just academic, it influences surgical candidacy, perioperative management, and even interpretation of AVS results. So before proceeding to surgery, this step is essential. The overarching principle is that PA-specific therapy, whether surgical or medical, reduces cardiovascular, renal, and metabolic complications compared to non-targeted therapy. Importantly, the guideline recommends avoiding ENaC inhibitors as primary therapy. Instead, MRAs should be used as the standard PA-specific treatment. And finally, management is individualized. Surgery is curative for unilateral disease, while lifelong MRA therapy is appropriate for bilateral disease. So in summary, the 2025 update reinforces the need for broad screening, more selective use of suppression testing, reliance on AVS for lateralization, thoughtful tailoring of therapy to laterality, and a pragmatic approach to medical therapy, emphasizing spironolactone as first line. As always, the goal is precise diagnosis and targeted treatment to improve outcomes for our patients with hypertension. And that's a wrap for today's episode. A quick focus dive into Endocrine Society guidelines on primary aldosteronism, just released 2025. Missed anything? Don't worry. I've taken all the notes for you. You can get the full summary delivered straight to your inbox. Just head over to www.easyendoprep.com and subscribe to the newsletter. Thank you for being here. And until next time, stay consistent and keep it bite-sized.